Hello and welcome to the Cardiology MCQ bootcamp. My name is Dr. Moses Kazevu. This is part 1 of 20 videos. Use this time to actually pause the video at any particular point so that you should be able to answer the question before I show you the answer on your screen. Stay tuned to the other videos and continue following the course as it will lay the foundations for the future classes that we'll have in this particular course. If you haven't yet checked out our online store, please head over there. The address is at the bottom there. That's payhip.com. MK/MK7 Medverse, spelled just like that at the particular bottom of your screen. I will leave it tagged in the description as well, where you could be able to purchase different books of different specialties, including surgery, which is 2 parts have been released. A 3rd part will be released very soon, and the 4th and final part. And then afterwards, the whole book will be released. Lecture notes on obstetrics and gynecology, lecture notes on emergency medicine, lecture notes on internal medicine, and of course our internal medicine course, where the rest of this video will be completed on. Question 1 up to 10 will be present on our YouTube channel and free of access, but question 11 up to 20 will be reserved for those that are part of the YouTube membership and for those that have access to our online course on our website. We will also offer other step-by-step internal medicine topic review on our online course, MCQ bootcamp revisions for other particular specialties like internal medicine, in terms of respiratory medicine, GIT, hematology, and so on and so forth. We will also provide this material that we will be using in forms of PPTs. Join our membership today. I'll leave the link tagged in the description below so that you can be able to watch these extended MCQ videos. If you don't want to partake of the online internal medicine course, you can just sign up for the YouTube membership. And of course, you'll have access to early videos before anyone else. So we'll begin with our question 1. A 40-year-old presents to accident and emergency with a retrosternal chest pain, which he had for 7 hours. On examination, he looked comfortable but was tachycardic and pyrexial. His physical examination was otherwise normal. His temperature, or rather his troponin T, is mildly elevated. His ECG is shown below. What is the most likely diagnosis? A. ST segment myocardial infarction. B. Brugada syndrome. C. Non-ST segment elevation myocardial infarction. D. Pericarditis. E. Gastroesophageal reflux disease or GERD. So we'll give you some time to now be able to pause your video so that you can write down your answers, so that you can scream it at your screen. All right. So off the bat, when we look at this particular question, this is a 40-year-old man that has presented to your ward, to your emergency department, and they've come in with retrosternal chest pain. Very important to keep in mind. And this has been there for 7 hours. He's tachycardic and he also has a fever, but otherwise the rest of the exam is normal. So his troponin T is mildly elevated. So this means that it has to be something that is affecting the heart. So already off the bat, that rules out your gastroesophageal reflux disease because the timing seems a bit off for you to actually have it for 7 hours. Okay, so off the bat, we can rule that out. Now, having a look at his ECG at the bottom here, remember when you're reading your ECG, your different steps at reading the ECG, the name of the patient, the age of the patient, when this ECG was done, at what time was it done. So the first thing that you're looking at, of course, is it well calibrated, or rather a standard calibration. You look at this tower here at the beginning. It's 1 box wide and 2 boxes tall. Of course, this is standard calibration, or you can look at the inscriptions here at the bottom, 25 millimeters per second and 10 millimeters per millivolt. So that's standard calibration. The next thing that you're going to be looking at is, of course, is this a regular rhythm? You can get a quick assessment by using your rhythm strip by lead 2. You can see that there's a P wave. There's a curious complex, there's a T wave, there's a P wave, a curious complex, a T wave, a P wave, a curious complex, a T wave. And of course, the distances between these curious complexes seems to be the same. So we can already conclude that this is a regular rhythm. Off the bat, if we look at the rate of this particular ECG, we can count the boxes, and remember that if it's between 3 to 5 big boxes, then that's a normal rate. So already we can see that this is 1, 2, 3. Even if this is an entire box, it's going to make 4. So between 3 to 5 big boxes, if you look at this ECG very quickly, the rate will be normal. We can also comment now on the cardiac axis. Lead 1 is facing upwards, lead 2 is facing upwards, but lead 3 is facing downwards. So possibly this is a physiological left axis deviation. Not anything to worry much about. It only becomes worrying if lead 2 is also facing downwards, and that becomes a pathological left axis deviation. We also look at the width of the Keres complex. It seems to be within 3 boxes, so that's not much of an issue in this case. Then coming now to the PR segment, you can see that the PR segment here, it seems like there's something that's going on here with the PR segment. It seems a bit depressed. Compared also to the ST segment, as you can see, there's widespread ST segment elevation from lead 1, 2, 3, V1, V2, V3, V4, V5, V6. And of course, there's this peaked T waves that seems to be also widespread. Off the bat, it's very tempting to actually go for a myocardial infarction, a STEMI, but that wouldn't be the answer here because the STEMI wouldn't give you this widespread picture. Moreover, it wouldn't give you any changes in the PR segment. So most likely that this is a patient that is having a pericarditis. So our best answer here is option D, which is a pericarditis. So remember that in that particular ECG, like I said, we have the widespread concave ST segment elevation. We have depression of the PR interval, which I already showed you on the previous ECG. So this is very much consistent with the acute pericarditis. We almost never see it in patients that come in with acute ischemia. And it's not really strange to see that you're going to have mildly elevated troponin levels in the blood. So it doesn't mean that a patient cannot have pericarditis. So it's not a strange thing. So often patients that come in with acute pericarditis are often mismanaged in the fact that they may be inappropriately given some thrombolytics, and then this can actually have serious consequences once you do this. And remember, the patient had a fever. Fever is a common thing that we see in acute pericarditis. So acute pericarditis is one of the pain that can actually mimic angina. It's very important to actually keep in mind. The treatment is actually with NSAIDs as the first line of treatment for acute pericarditis. It's a self-limiting thing. It tends to resolve within a few weeks. So just to give you a little bit of some background and a summary on pericarditis, remember that the heart is going to be covered by this layer, which is known as the pericardium. And inflammation of this layer that is surrounding the heart, that's known as the pericardium, is known as pericarditis. Predominantly the fibrous sac of the heart. So it can be acute, it can be subacute, it can be chronic. The causes could be subclassified according to viral causes, which are the most common, things like Coxsackie virus, HIV. It could be after an MI. It could be happening in the first 1 to 3 days or even late. They could have what is known as Dressler syndrome. They could have an autoimmune condition like an SLE or rheumatoid arthritis. They could have infections like TB, bacterial infections like staph, fungal infections. You could also even have some neoplastic spreads to the pericardium. It could be a primary tumor of the pericardium, or it could be a metastatic tumor, which tend to be quite rare. You could have patients that have uremia, a uremic pericarditis. So often there's a patient that is maybe advanced kidney disease. They come in and they're acutely decompensated. And there's a patient that may have a pericardial friction rub. Remember that uremic pericarditis is one of the indications why you may need to take your patients for dialysis. And then it could be drug-induced, so things like hydralazine and isoniazid have been implicated, and then trauma is even post-surgical. So often these patients present with a characteristic type of chest pain that's described as sharp, and often this pain is going to be pleuritic in nature. It's going to be relieved by leaning forward, and it's worsened by laying flat. So when you see a patient with that particular demographic, quickly get an ECG. You're going to see that widespread ST segment elevation. You may see depression of the PR interval. Then you may sometimes have a friction pericardial rub. It sort of sounds like two balloons rubbing against each other. You may get a fever, you may get malaise, you may get signs of a pericardial effusion or a tamponade. Investigations you want to do, of course, an ECG, which we have already done in this patient, an echo to assess if there is an associated effusion. You also want to get some inflammatory markers as well as some troponins to rule out myocarditis, as well as to check the renal function of the patient. Get a chest x-ray which may show an enlarged cardiac shadow. And of course, in terms of the management, our first line is going to be our NSAIDs or ibuprofen. You can combine it with colchicine. Steroids can sometimes be used, especially for the autoimmune conditions or if it's refractory. And of course, we want to address the underlying cause. If it's a malignancy, treat them for that. If it's a TB, treat them for that. If they have an effusion and it's causing a cardiac tamponade where their heart sounds are a bit distant, the BPs are dropping, you may want to drain the fluid. So you want to do a pericardiocentesis, an ultrasound-guided pericardiocentesis. And then often pericarditis may complicate into a pericardial infusion. It may complicate into cardiac tamponade, which may impede the heart's ability to fill up with blood. It may also result in a constrictive pericarditis. We move on to question 2. A 60-year-old male patient on aspirin, nitrates, and a beta blocker being followed up for chronic stable angina presents to the ER with a 2-day history, 2 to 3 episodes of more severe long-standing anginal pain each day over the past 3 days. His ECG and cardiac enzymes are normal. The best course of action of the following is A, admit the patient and begin intravenous digoxin. B, admit the patient and begin intravenous heparin. C, admit the patient and give prophylactic thrombolytic therapy. D, admit the patient and observe with no change in medication. E, discharge the patient from the ER with increases in nitrates and beta blockers. So I'll give you some time to think through this video and think through the question. You may pause the video at this particular moment. So having a look at this patient, you get a 60-year-old male patient. Of course, they are on some medication. Nitrates are vasodilators, aspirin, blood thinners, blood thinners, and beta blockers are going to be used for many different conditions. But this is a patient that has had chronic stable angina. So probably they have an atheromatous plaque that is there. They've been having it for a long time. And all of a sudden, they have worsened over the past few days. They've had episodes of longer lasting pains. And of course, they've been getting worse over the past 3 days. So it means that stable angina is no longer considered as stable angina in this case, because this is a patient that has worsened. And most likely, this has become unstable angina. So if we look at these particular options that we have here, of course, you're not going to do nothing about this patient because they've worsened. Something needs to change in this particular patient. So option D already off the bat will be ruled out because you have to change the medication. Then discharging the patient, whilst you're increasing the nitrates and the beta blockers, may not be the right thing for this particular patient because you may need to actually anticoagulate the patient. This person has a risk of actually progressing to an MI. Then giving them prophylactic thrombolytic therapy, these are actually not really indicated in unstable angina, and in some cases they may actually worsen your outcomes. Digoxin also is not indicated because this is a patient that's not even in failure, for example. Then they don't have an atrial fibrillation that they've told us, so there is no indication for giving digoxin. So this actually leaves us with the option B as our correct answer. So B is the correct answer. So remember, this is a patient that has unstable angina. They have progressed from the chronic stable angina. So this is a patient that needs intravenous heparin. And in this case, we're going to be giving our low molecular weight heparin or enoxaparin. Remember, this one has a quite short half-life, and it means that if the patient actually incurs side effects, it can easily be stopped and cleared out from the body. So there is no role, like I told you, for digoxin in this case. And more so, remember, digoxin will increase the contractility of the heart. So it means that it's going to increase the myocardial oxygen demand. And of course, it may exacerbate the situation. Thrombolytic therapy, like I said, in the face of the unstable angina is not really indicated unless if a patient actually has a documented myocardial infarction. So in some cases, we may actually have a very early interventional cardiology getting in to catheterize the patient and performing an angioplasty, or they may also even put a stent, possibly in conjunction with other drugs like the glycoprotein 2B3A inhibitors. Now, keep in mind that traditionally angina is classified into three main types for the sake of explaining what it is. So you have the stable angina, which is associated with atherosclerosis. So here there'll be a lot of these, what we call bad lipids. Remember, there are bad lipids and good lipids, the low-density lipoproteins and the high-density lipoproteins. The high-density lipoproteins are the ones that are the good lipids. So they have a high density of the protein component and low density of the fat component, while the low density lipoproteins are the bad lipids that have low density of proteins and a very high fat content. So these tend to infiltrate into the walls of the endothelium, and then they're going to be engulfed by macrophages that will eventually form these type of cells, which are known as foam cells. And then these ones are eventually going to form the plaque that we see here. That's going to be surrounded by the fibroblasts. It's going to be surrounded by the smooth muscle cells. There'll be a fibrous cap that is surrounding there, closing it off. Now, as long as this fibrous cap is intact, remember that you're going to be reducing the lumen and the size of this blood vessel. And a patient is only going to become symptomatic where now the oxygen demands are much greater than the supply. For example, they start exercising, because this here becomes fixed and the amount of oxygen or the amount of red blood cells passing through is going to be limited. So if someone is exercising, they become symptomatic. So this is what's happening in stable angina. Often they'll get symptoms when they start exercising, and at rest they won't have any symptoms. Then in some cases it may progress, so the surface of this clot may undergo certain ulceration, it may undergo transformation, where it releases this thrombogenic material that can cause platelets to actually aggregate and further reduce the size of the lumen. So this will further reduce the amount of blood flow that is going to the myocardium. And by this reduction of this blood that's going to the myocardium, it means that there's going to be some ischemia, there's going to be pain. And this pain now will be worsened from their baseline. So it will be a person that had stable angina, pain during exercise, now they start to get even pain at rest. Then in some cases, it may not be associated with atherosclerosis. So for example, for some reason, there's some spasms that are happening in the walls of the blood vessels. This is very common early in the morning. We refer to this as Prinzmetal angina or the variant angina. So those are the three main types of angina: stable and unstable, associated with atherosclerosis, whilst the variant is usually associated with the coronary spasms and it's not going to be associated with atherosclerosis. So generally, when you treat these patients, you want to relieve the ischemia. You want to prevent this patient from going into a full-blown myocardial infarction. You want to stabilize the plaque, and you want to reduce the thrombus from forming. Because remember that in someone with this stable angina, they can progress to unstable angina. And someone with an unstable angina can progress to a full-blown MI. You also want to risk stratify this patient, because it will help you guide whether the treatment that you're going to offer is invasive or whether it's a conservative. So generally, the risk stratification is going to be classified based on the changes that you're seeing on the ECG, based on the levels of the troponin that are there, and the hemodynamic status of the patient. For example, you get a patient that is having a lot of chest pain. You get a patient that is hemodynamically unstable. Their BPs are tanking. This is a patient that should have urgent invasive strategies, less than 2 hours. Maybe take them for a coronary angiography, assess the anatomy. You can perform a percutaneous coronary intervention. And then those that are high risk is if they have some dynamic changes on the ECG, their troponins are elevated. These invasive strategies must be done early, within the first day. If they're low risk, then generally these ones are going to be taking a conservative approach. In some patients, for example, if three major arteries are actually involved, they may actually qualify for a CABG, which is the coronary artery bypass graft, especially if there's a left main involvement or these three main vessels that are involved. So some of the medications that we often use in the management of angina are going to include things like antiplatelet drugs. These are going to be preventing the thrombus. Examples are aspirin, which is of course COX, a cyclooxygenase inhibitor, and it's going to be preventing the platelets from being activated and aggregating. You have the P2Y12 inhibitors like clopidogrel that can be used. Then anticoagulants are going to be reducing the clot propagation. In this case, the low molecular weight heparin or the fondaparinux can be used. Nitrates are vasodilators. They relieve the chest pain, so your sublingual or your IV nitrates can be given. Want to reduce the oxygen demand, so give them a beta blocker. But of course, remember, these ones are not going to be given for patients that are in heart failure. It's not going to be given for patients with bradycardia. And then in terms of statins, these are going to help stabilize the plaques. So usually we give them a high dose of the statins, like atorvastatin. And then oxygen is given if they're hypoxic, especially if their saturations are less than 90%. Morphine is a bit of a dogma, and generally we tend to avoid it because it can mask the symptoms, and you may not really know when your patient actually worsens. But in some cases, we do offer morphine to these patients. In terms of the anticoagulants that you should keep in mind, just as a sidebar or a side note that are very important for the purposes of your exams, you have your unfractionated heparin. Remember how it works is that it's going to activate an enzyme that's known as antithrombin 3. Once antithrombin 3 has been activated, this is going to inhibit thrombin, which is activated factor 2, and then it's also going to inhibit factor 10. So we can use this in the management, in the acute management. We can use this for patients that we're planning to take for PCI, and monitoring actually is going to be requiring the activated partial thromboplastin times. And in terms of low molecular weight heparin, this one is going to be given as a parenteral route. Is going to be given subcutaneously. It can be preferred to the unfractionated heparin because it has a shorter half-life. And this one is going to be inhibiting factor 10, activated factor 10, also through the action of antithrombin 3. So to actually monitor the effects of heparin, we actually monitor the levels of factor 10. It's a common misconception to think that the INR is used to monitor the functionality of heparin, but rather INR is only used to be monitoring the functioning of warfarin. It's not used to monitor the function of heparin. We should use activated factor 10 levels to monitor the function of heparin. So often the low molecular weight heparin is used for the non-ST segment elevation acute coronary syndromes, including the unstable angina. It's predictable in terms of the dosing. Of course, there's less monitoring that you often require, and you are going to be keeping your patients, or the reversals is very quick because it has a shorter half-life. The fondaparinix is a synthetic pentasaccharide that is going to be a selective inhibitor of activated factor 10, and it also works through antithrombin 3. It can be used as an alternative to low molecular weight heparin. It has a lower bleeding risk profile, and often we use it when we are doing conservative management strategies. Bivalirudin is going to be a direct thrombin inhibitor, so it's going to be binding to both the thrombin which is free or circulating, as well as the thrombin which is bound. And often this is used during the PCI, especially in patients with unstable angina. We use it in patients in an NSTEMI, and especially if the bleeding risk is actually quite high, or if a patient has an HIT, a heparin-induced thrombocytopenia. Then we have the newer drugs, which are the direct oral acting anticoagulants, the DOACs, like rivaroxaban and apixaban, which are direct inhibitors of factor 10. These ones are not really the standard first line, but they have been studied in acute coronary syndromes, and they may be used in some patients, especially those that have a concomitant atrial fibrillation. But those are just some of the anticoagulants you need to keep in mind. Moving on to question 3, a 60-year-old white female presents with epigastric pain, nausea, and vomiting with heart rate of 50 and a pronounced first-degree AV block on ER cardiac monitor. The blood pressure is 130/80. The coronary artery most likely to be involved in this process is A, the right coronary artery, B, the left main, C, the left anterior descending, or D, the circumflex. I'll give you some time to pause the video and write down your answer. So this is a question that is going to be testing your basic anatomy, because if you haven't passed through your basic anatomy, it's very difficult to answer such a particular question. So remember that even though the heart carries oxygen in it, that is oxygenated, the heart muscle itself is quite thick to actually be supplied by the oxygen that it carries by diffusion alone. So that's why there's a special system that was developed that's known as the coronary system that is going to be taking blood and supplying blood to the myocardium. These coronary arteries are going to be branching off straight from the aorta, and you're going to have two main coronary arteries, your right coronary artery and your left coronary artery. Those are very important. Now, these are going to be supplying blood to several structures, and the one that often supplies blood mainly to the structure that actually is the SA node and controls the SA node predominantly is going to be a branch or coming from the right coronary artery. Because remember, this is a patient that has presented with an MI, and of course, they've presented with first-degree AV block. They've presented with a pulse rate of 50, so they've presented with bradycardia, and they have a history of an MI because they have the epigastric pain, the nausea, and the vomiting. And remember that sometimes the presentation of MI may be very, very weird. You may actually just have nausea and vomiting as the only thing that is presenting. So most likely this is involving a vessel that is going to be supplying the SA node and involving a vessel that is going to be supplying the AV node. So that, like I said, it's going to be the right coronary artery. So remember, your right coronary artery will be supplying the inferior myocardium, and it will be supplying the AV node in about 70% of the patients. When this artery has been occluded, it leads to ischemia. So it's going to be leading to the bradycardia, which we see in patients that come in with an inferior MI. So sometimes the AV block can be associated with an anterior MI, especially if the left anterior descending artery is closed. And remember that this left anterior descending artery is also often referred to as the widowmaker, because most times if this artery gets blocked, it has a higher risk of mortality and patients actually dying. So it means that there's a greater myocardial area that is involved in this particular blockage of the left anterior descending artery, as well as the hemodynamic instability is more prominent with the left anterior descending artery. So here is the coronary artery that I want you to focus on the right of your screen. So as you can see here, we have the aorta coming out from the left ventricle. It just as it comes out, it divides into the left main coronary artery and the right main coronary artery. So your left coronary artery is going to be pretty much dividing into two main branches. There is what is known as the left circumflex, and there's what is known as the left anterior descending artery. So as you can see, the left circumflex will wrap around the heart, and it's pretty much going to be supplying the anterior portion of the interventricular groove. It's also going to be supplying the anterior wall of the left ventricle, and then it's going to be supplying the 2/3 of the interventricular septum, as well as the apex of the heart. Then you have so that's this one here, the left anterior descending artery. So it supplies a large portion of the heart. Then you have your circumflex artery, which is going to be supplying the the anterior ventricular groove, and it's going to be supplying the lateral aspect of the heart and even the posterior aspect of the left ventricle, and to some extent the left atrium. Then the right coronary artery is the one that is important, and it's the one that's commonly tested on exams, because the right coronary artery is going to be originating from the aortic sinus, and then it will run in its groove, then eventually in the right atrioventricular groove rather, and it's going to be dividing into two main branches. You have your posterior descending artery, and then of course you have your right marginal artery. And remember that the right marginal artery will supply the right ventricular wall, and then the posterior descending artery is the one that's going to be supplying the 1/3 of the interventricular septum. Is also going to be supplying the inferior wall, especially for those that have whether depending on the dominance that they have. And remember that for those that are right dominant circulation, the posterior descending artery will come from the right coronary artery. For those that are left dominant circulation, which is in about 10 to 15%, then the posterior descending artery will come from the left circumflex. Then for those that are co-dominant, then the posterior descending artery will be supplied by both the right and the left, the right coronary artery and the left circumflex artery. This is very important to remember, because remember that branches that are coming from the right coronary artery are also going to be supplying the SA node. They're also going to be supplying the AV node, such that if there's a blockage in this right coronary artery, it will result in a person having an MI and they present with a bradycardia. So which is why it's also important to remember, like I said, the LAD occlusion is what's referred to as the widowmaker, because it causes a large portion. As you can see, the left anterior descending will supply this entire portion, the anterior portion of the left ventricle, and a huge portion of the lateral part of the ventricle. Then it means that if there is a blockage of this, extensive damage is happening, and most likely the patient comes in shock, and patients usually demise. Then in terms of the right coronary artery, like I said, it will cause an inferior MI, and it will also cause blockage, an AV nodal blockage. Then the left circumflex is going to be causing a lateral wall MI. Those are very important, especially when you're doing your angiography, but also for the purposes of your exams and to be able to pass your exams. Moving on to question 4. A 65-year-old man presents with a central crushing chest pain for the first time. he is transferred immediately to the closest cardiac unit to undergo a primary percutaneous coronary intervention. There is thrombosis of the left circumflex artery, angioplasty is carried out, and a drug-eluting stent is inserted. What is the most likely change that to have occurred on the ECG during admission? So if you followed what was actually being discussed on the previous slide, you should be able to answer this question. A, ST segment depression in leads V1 to V4. B, ST segment elevation in leads V1 to V6. C, ST segment depression in leads 2, 3, and AVF. D, ST segment elevation in leads V5 to V6. E, ST segment elevation in leads 2, 3, and AVF. Okay, so this one is a very interesting question in that it's going to be testing, number one, if you're able to localize a lesion. Number two, it's going to be testing if you know the changes to expect on the ECG. So let's have a look at this particular question. So this man who's 65 has presented with a crushing chest pain. So obviously this is an MI and has undergone a percutaneous coronary intervention. So it's a confirmed MI. And the left circumflex artery is the only thing that is involved. And remember from the previous discussion, we say that the left circumflex artery is going to be supplying the lateral aspect of the heart. And they inserted a stent. So all this is asking you is what is going to be responsible for the lateral aspect of the heart. Already, if you don't already know, for an MI, you're going to be seeing ST segment elevation or for these MIs, so especially the ones that are taken to a PCI. So off the bat, you can rule out depression, you can rule out the option A and option C, because those usually are going to be pointing towards ischemia rather than infarction. Then ST segment elevation in V1 to V6, this is a very large portion, anterolateral type of MI and even involving the septum. Then 2, 3, and AVF represented the inferior portion of the heart. So that would be, for the previous question, if you did an ECG, you would see changes in ST segment elevation in leads 2, 3, and AVF for the inferior MI with the bradycardia. But of course, V5 and V6 represent the lateral aspect of the heart. So most likely, you're going to be seeing changes in V5 and V6. So the correct answer there is option D. So remember, when you're connecting your ECG, you're going to be connecting it in a specific way. So when you look at your ECG machine, it has inscriptions on it. So it will have one that has an R inscription on it, representing that you're connected to the right arm. You have one that has an L written on it, meaning you're connected to the left arm. There'll be one that will be written as an N, which means you're connected to the right leg. And there'll be one that will have an inscription F, meaning you're connected to the left foot. So those are what we call the ones that are connected to the limbs. These are the ones that are going to be predominantly forming up the limb leads. And remember that these limb leads have a different way of looking at the heart. Lead 1 looks at the lateral aspect of the heart, while lead 2 and 3 looks at the inferior aspect of the heart. Then you have what are known as chest leads, which are connected over the chest, V1 to V6. V1 is connected in the fourth intercostal space, the right of the sternum. V2 is the fourth intercostal space, left of the sternum. It's common misconception that people connect them here, which is quite high, where they auscultate for the heart. Do not connect them there. Connect them here or the fourth intercostal space. Then you skip V3 and you connect V4 where the apex beat is. That's the fifth intercostal space, mid-clavicular line. Then halfway between V2 and V4, that's where you put your V3. Then V5 is going to be the fifth intercostal space. It's going to be the anterior axillary line. So it will be in line with V4. Then V6 is going to be mid-axillary line in line with V4 and V5. So this is how you're going to be connecting them. These will have a different look at the heart as well. V1 and V2 look at the anterior aspect of the heart. V3 and V4 look at the septum. V5 and V6 will be looking at the lateral aspect of the heart. And as you can see, this is a diagram of the coronary artery system, which I already explained in the previous question. So to take home the message, lead 2, 3, and AVF look at the inferior aspect of the heart, which is supplied by the right coronary artery, the posterior descending branch. V1 and V2 represent the anterior aspect of the heart. So that's the left coronary artery. That's a diagonal branch of the left anterior descending artery. Then V3 to V4, we'll look at the septum. So that's the septal branch of the left anterior descending artery, these are all branches of the LCA. Then V5 and V6 is the lateral aspect, which is coming from the left circumflex artery, coming from the left coronary artery. And then V1 to V6, meaning it's going to be an anterolateral, which is a left main stem disease. So if you get some changes in V1 to V6, it means that that's quite an extensive type of MI. Moving on to question 5, you are seeing in your office a patient with chief complaints of relatively sudden onset of shortness of breath and weakness, but no chest pain. ECG shows non-specific ST changes. You would be particularly attenuated to the possibility of painless or silent myocardial infarction in A. Advanced coronary artery disease, patients with unstable angina on multiple medications, B. Elderly patients, C. Premenopausal females, D. Inferior MI patients, E. MI patients with PVCs, which are the premature ventricular contraction. The temptation to actually go for either option D or option A is very high because we've been discussing about MIs in the past questions, but that would be wrong. And I'm sure most of you are looking for the option that is telling you that diabetic patients, because that's what you know, that diabetic patients are the ones that are predisposed to silent MIs, but also that option is not there. So the best option here is option B. So remember, this is a silent MI. We often expect silent MIs in patients that are elderly. We expect silent MIs in patients that are diabetic. So if they just tell you that I'm tired or I'm feeling tired, do not take that lightly, especially in a patient that is diabetic and a patient that is, of course, elderly. Investigate them for that. So this is just an atypical type of MI where remember that the classical presentation of MI is going to be this heavy, crushing substernal chest pain or pressure. But in some patients, it may be painless, especially in diabetics, especially in the elderly. So they'll just present with dyspnea, or they'll present with weakness, or they may just sometimes present with atypical things like altered mental status. They may have suddenly come in with an arrhythmia, or they come in with hypotension. The reason why often these patients, especially diabetic patients, don't feel that pain is because they have that absent pain response because of the autonomic dysfunction that is there. So generally, the other choices that we have in the options, they don't include diabetics. So the most closest answer is, of course, the elderly patients. Now, just before we actually leave the discussion on MI, I just wanted us to talk a little bit about cardiac biomarkers, as well as the enzymes that we use in MI, because it's very important to actually remember this for the purpose of your exams. Now, the take-home messages that I want you to keep in mind is that the quickest marker, or the earliest rise that is going to rule out your MIs within the first 3 hours, is going to be your myoglobin. It's the earliest marker. So within 1 to 3 hours, if the heart is being infarcted, the levels will rise. But then again, this is not so specific, because where do we find myoglobin? We also find it in skeletal muscle. So this has a very low specificity. For example, if someone has incurred trauma, levels of myoglobin are going to increase. So this actually on its own will have very little diagnostic value. It tends to peak within 6 to 9 hours, and then it returns after 24 hours. So if it's the only thing that is there, you could use that as a surrogate to help you make a diagnosis of an MI. Then afterwards, the ones that tend to rise in a relatively early manner is you're going to be using your troponins, which can rise in about 3 to 12 hours. Now, these troponins also rise relatively early, not as early as the myoglobin, but they rise relatively early, and they are going to be specific and sensitive to myocardial necrosis, myocardial damage. So often if you get rise in this, it means that there is some damage to the myocardium. Now, even with the very small infarcts, you get a huge rise in the levels of the troponin I, and the troponin T. So these are going to be used as the gold standard. The problem with these is that they take about a week or 2 weeks to actually return back to normal. Because remember, these enzymes and these proteins are leaking out in the blood. They should be filtered out, so they have a half-life. So often it takes about 7 to 14 days for them to return back to normal, which is a very long time. Now imagine you get a patient that is admitted to the ward. They get an MI. You treat them for the MI. A few days later, the chest pain comes back. You're not so sure if whether the patient has reinfarcted or not. If you do your troponins, they'll still be elevated, so they're not going to be helpful in that case. So they're not going to be so helpful in detecting a reinfarction, which is where the CKMB comes in, the creatine kinase MB. So this one also rises quite early, and it peaks in 24 hours, but it drops within 2 to 3 days. It will drop back to normal. So when someone now is suspecting that there's a reinfarction that has happened, you want to get your creatine kinase enzyme, because these are the ones that are going to be helping you detect when a reinfarction has taken place. Then you have other things that can be used as surrogate markers that are now rarely used, like your LDH, which rises in 24 to 48 hours. It peaks at 2 to 3 days, and then it returns to normal in about 10 to 14 days. These ones are rarely used. They have now become obsolete. Even things like your AST, which rises in about 6 to 12 hours, then it peaks in about 24 to 48 hours and it remains about 3 to 7 days. So remember, even with liver disease, you may get a rise in AST, given that a lot of people drink alcohol. Then you can have your beta natriuretic peptides, which are variable. So these ones, generally, they rise very rapidly in an MI, but of course, they are poorly specific, because even in heart failure, even in pulmonary embolisms, you're going to be seeing high levels of the natriuretic peptides. So take-home message from this: number one, the most sensitive markers are the troponins. Number two, the markers that we're going to be using for reinfarction are the CKMB, because it has a shorter half-life, and myoglobin has the earliest rise, but of course it's non-specific. So everything that you do must be interpreted in the context of your clinical. So when they come in, you do your serial measurements of your cardiac enzymes. You do them at the baseline. You do them after there's a protocol that allows you to do them after 2 hours. You can do them after 3 hours to 6 hours. You can do them after 12 hours. Now, even there's a highly sensitive C-reactive protein that's also being included in these biomarker workup, especially for patients that come in with MI. So here's a graph that's showing you exactly, as you can see here, there's a rise of troponin, which is this color here. It rises quite early, and then of course it comes down to normal. This is with perfusion or reperfusion, and then without perfusion it remains quite elevated even for longer than a week. Then in terms of the CKMB, it rises early, and then it of course gets back to baseline quite early. Without perfusion, even with perfusion, it gets back quite early. And this is also another graph showing you the different rises. As you can see, myoglobin is the fastest rise. LDH takes a bit of some time, and then the troponins are the most specific. The CKMB will come back to baseline quite early. Moving on to question 6, a 78-year-old woman is admitted with heart failure. The underlying cause is determined to be aortic stenosis. Which sign is the most likely to be present? A, pleural effusion on chest x-ray. B, raised jugular venous pressure. C, bilateral edema. D, bibasal crepitations. E, atrial fibrillation. I'll give you some time to pause the video, write down your answer, scream it at the screen. If you're not attempting these questions, then it defeats the whole purpose of this exercise, because it helps you test your knowledge so that you can be able to answer your questions on your board exams, and you can have a proper understanding when you see patients in real life. So remember that heart failure anatomically is going to be divided into left-sided heart failure and right-sided heart failure. And you have a biventricular heart failure. So remember that the left side of the body is going to be receiving blood from the lungs, and it's going to be pumping blood to the systemic circulation, whilst the right side of the body is receiving blood from the body, and it's going to be pumping blood to the lungs. So if the left side has failed to work, the blood is going to flow back to where it's coming from. I like to use an analogy. Suppose you're going into town and there's a roadblock, and that's the only road you can use. The next logical thing is, of course, not to fight the police, but the next logical thing is to go back. So you turn back. So if the left side is not working because there's a stenotic outflow valve, this blood is going to flow back. And where is it going to flow back? Back into the lungs. So this is going to be causing edema in the lungs. It's going to be causing congestion in the lungs. So you're going to be noticing extravasation of fluid because the hydrostatic pressures in the lungs are going to increase. So looking at these options, pleural effusion is unlikely with the left-sided. Your right JVP, we see that with right-sided failure. Your bipedal edema, you see that with right-sided failure. Your atrial fibrillations are common they're not really specific for left or right-sided heart failure, but bibasal creps, meaning that fluid is extravasating in the lungs, we see that commonly with left-sided heart failure. So our answer here is your bibasal crepitations, which is your option D. So like I said, aortic stenosis causing a left ventricular heart failure. So the valve is quite narrowed. It's very difficult for blood to flow forward. So some of this backs up in the lungs. It causes pulmonary edema in the lungs, and it will cause the bibasal crepitations. These happen much early. Before even the effusion can be seen on the X-ray, you'll be able to hear these basal creps posteriorly, the baselines. On the X-ray, you may see other things like cephalization, where the vessels that are going to the upper portions of the lungs are going to be dilated, while those that are going to the lower portions will not be dilated. This is the opposite of what normally should be. Most blood should be going to the lower bases of the lungs. You may see these curly B lines, which are infiltrates of the interstitium. Then, of course, if there's a backflow on the right heart, you're going to see right-sided features, things like raised JVP, bilateral pedoedema. And like I said, atrial fibrillation may coexist with aortic stenosis, but most commonly it's associated with mitral stenosis and an enlarged right atrium as well. So just to remind you, right-sided heart failure, you're going to have congestion in the peripheral tissues. Left-sided heart failure, you're going to have congestion in the lungs. So you're going to be having pulmonary congestion, which will impair your gaseous exchange. So the patients who have cyanosis and features of hypoxia, you're going to have pulmonary edema that can cause this cough with this frothy sputum. You can have orthopnea. You can have paroxysmal nocturnal dyspnea, where they wake up at night to catch a breath. There's decrease in the cardiac output, so it means they'll have this active intolerance, this easy fatigability. On the right side, there's congestion in the peripheral tissues. If it's happening in the liver, they may have impaired liver function. They may have a slight tender hepatomegaly. They may have congestion in the GIT, which can cause them to be anorexic. It can cause them to have GI distress, weight loss. And of course, depending on where it is, they can have raised JVP, they can have bilateral pedoedema, they can have anasaka, which is this generalized edema. So to make a diagnosis of this clinically, way back, they used to use what is known as the Framingham's classification, which groups them into the major criteria and minor criteria. So to make a diagnosis of heart failure, this is a very good bedside clinical tool that can actually help you because it just uses findings that you have on history and even some simple investigations. So you're going to be doing if you have two majors and if you have one major and two minors, then most likely heart failure is present. So the minor are only valid if no other condition can explain that symptom. Because remember, some of these symptoms can be explained by other things like COPDs, they can be explained by cirrhosis, they can be explained by nephrotic syndrome. So the major criteria are things like PND, your paroxysmal nocturnal dyspnea, neck vein distension, or your JVP elevation, pulmonary crackles. You can have radiographic features of cardiomegaly on the X-ray. That's your increase in your cardiothoracic ratio. Acute pulmonary edema, a third heart sounds, increase in the central venous pressure, hepatojugular reflux, weight loss greater than 4.5 kg in 5 days in response to treatment. Then minor criteria are things like bilateral ankle edema and nocturnal cough, dyspnea on ordinary exertion, hepatomegaly, pleural effusion, decrease in the vital capacity by 1/3 of the maximum recorded, tachycardia greater than 120. That's what we refer to as a Framingham's classification. Remember that generally in modern practice, the criteria itself is quite sensitive, but it's not so specific because there are many conditions that can explain all of these features. So in modern practice, we often rely on an echocardiograph, and if there's one blood test that you should do is the NT-proBNP, the nitrogen terminus pro-BNP, brain natriuretic peptide or beta natriuretic peptide. But of course, in places where resources are quite limited, we can actually still use the Framingham classification to help us make a diagnosis of heart failure. Coming now to question 7, a 75-year-old African American female is admitted with acute myocardial infarction and congestion or congestive heart failure, then has an episode of ventricular tachycardia. She is prescribed multiple medications and soon develops confusion and slurred speech. The most likely cause of this confusion is A, captopril, B, digoxin, C, furosemide, D, lidocaine, E, nitroglycerine. So again, this is a question that is helping you understand whether you know what you're dealing with. So you have a 75-year-old female. She's quite elderly. She's come in with an acute MI. So she already has a structural defect. She has congestive heart failure. And of course, she has the ventricular tachycardia. So what's the treatment of ventricular tachycardia in a patient with structural defect? And not only that, it's also going further to test whether you know the complications. This woman develops confusion and slurred speech. So off the bat, ignoring everything that's on top here, if we look at the options, captopril is an ACE inhibitor, so it will often cause a cough. No history of a cough here. Digoxin toxicity often causes yellowing of the vision, which is the xanthopsia. None of that. Furosemide, which is a loop diuretic, is ototoxic, so may cause some hearing problems. It may cause dehydration. It may cause electrolyte imbalances. Not really mentioned here, but confusion can be caused by the furosemide, but furosemide will not explain the slurred speech. Nitroglycerin will cause a headache because it's a vasodilator, but lidocaine is used for the treatment of ventricular tachycardia, and it has been known to cause confusion and slurred speech, especially in the elderly patients. So most likely the answer there is lidocaine. So remember that this person has neurological symptoms, and the only cardiovascular medication likely to do this is the lidocaine. It causes confusion, especially in elderly patients. They may cause other things like tremors, convulsions, respiratory depression, bradycardia, and hypotension. I just want to talk a little bit about the antiarrhythmic drugs because this is a high-yield thing, especially for exams. So they're divided largely into 5 classes. The class 1 is for the sodium channel blockers. Class 2 is for beta blockers. Class 3 is for potassium channel blockers. Class 4 is for calcium channel blockers, and Class 5 is for miscellaneous or others. There's a nice mnemonic that I learned, which says STOP, S for sodium channel blockers, STOP, beta for beta blockers, STOP, blocking, as in stop blocking potassium channels only. So STOP for sodium, blocking for beta blockers, potassium for potassium channel blockers. So stop blocking potassium channels for calcium channel blockers and only for others. And you imagine you're in an exam and you remember the mnemonic and you forget what it actually stands for. That's exactly what has just happened to me. So we have our sodium channel blockers. Of course, these ones are going to be blocking our fast acting sodium channels. So these ones are going to be decreasing the conduction velocity of the action potential. So these are going to be used for patients with supraventricular tachycardias, as well as ventricular arrhythmias. So these ones are good for patients that have these SVTs. They are good for patients that have ventricular arrhythmias. But we avoid these in patients with structural heart disease. So avoid them in patients with structural heart disease. The fact that they actually block or reduce the conduction velocity of the action potential, it means that you increase the duration of the action potential. Once the action potential has increased duration, it means this actually predisposes the heart to developing other arrhythmias. So I know it's like a paradox. You're giving a drug to stop an arrhythmia, but you're predisposing this patient to developing even more arrhythmia. So there's a risk of them developing torsades because of widening of the QRS complex. It also has some CNS toxicities, especially with class 1B and negative inotropy. So class 1, the sodium channel blockers are divided into 1A, B, and C. 1A are drugs like procainamide, quinidine, and disopyramide. These ones are moderate sodium channel blockers. They also increase the action potential duration. So they're used for Wolff-Parkinson-White syndrome, ventricular tachycardias, and atrial fibrillation. They're contraindicated in patients with heart block and prolonged QT syndromes. Then they may cause torsades. They may cause lupus-like reactions, like for example with procainamide, and anticholinergic effects with disopyramide. Then class 1B, which is the mexiletine as well as lidocaine, which was given to our patient. These are weak channel blockers. They tend to decrease the action potential. So these ones are not going to be arrhythmogenic because they'll decrease the action potential. So there's no risk of the torsades. So these ones are used with acute ventricular tachycardia, especially in patients after an MI. Avoid them in liver disease. Avoid them in patients with seizures. They cause CNS toxicity, confusions, tremors, and seizures, which the patient had. Then class 1C is flecainide, and propafenone, which are strong sodium channel blockers. They have no change on the action potential duration. They are also pro-arrhythmic. They may cause conduction blockade. So these ones are used for supraventricular tachycardia. They're used for atrial fibrillation if they don't have any underlying structural defect. Avoid these in ischemic heart disease. Avoid them with left ventricular dysfunction. The beta blockers are predominantly, the ones we use are the these cardioselective beta blockers, metoprolol, esmolol. Even though propranolol is not really cardioselective, it's also going to be affecting the blood vessels. Well, there's one weird beta blocker that's not in this class, but sotalol. Sotalol is quite dynamic because it will have different types of actions. It can actually fall in more than one class, but often most classifications will put it in class 3. Then these ones are going to be blocking your beta adrenergic receptors, so it means that they're going to reduce the sympathetic drive. They're going to reduce the AV conduction, so they will reduce the rate in atrial fibrillation. They'll work for supraventricular tachycardias. They suppress the ventricular tachycardias. They also work for the post-MI prophylaxis. We avoid this in patients who are diabetic. We avoid them in severe asthmatic patients and avoid them with severe COPDs, with bradycardic and AV blockade, because they can potentially cause bronchospasms, they cause fatigue, they can cause bradycardia, they can cause hypotension. Then our class 3, our potassium channel blockers, your amiodarone, very famous drug. This one here must be avoided in thyroid patients, because remember, amiodarone, IOD, to remind you that there's iodine in this. So it can cause hyperthyroidism, can also cause hypothyroidism. So often avoid amiodarone in liver disease, avoid amiodarone in lung disease because it can cause pulmonary fibrosis, and avoid it also in thyroid disease. It can cause hyper or hypothyroidism. So these ones are going to be prolonging repolarization, so they increase the action potential duration, so there's predisposition to torsades. There's risk of pulmonary fibrosis, thyroid dysfunction, which I've already talked about, and hepatotoxicity, which I've talked about with amiodarone. They are used for atrial fibrillation, ventricular tachycardias, even ventricular fibrillation for suppression. So they prolong the QT interval and they can cause bradycardia. Then the calcium channel blockers, these are cardioselective, verapamil, diltiazem, even though diltiazem has some effect on the blood vessel, but verapamil is cardioselective. They block the L-type calcium channels and they reduce the AV conduction. So they're used for rate control in atrial fibrillation and supraventricular tachycardia, but avoid them in those with the severe left ventricular dysfunction. Those in acute failure, avoid calcium channel blockers. Avoid them in those with heart block, avoid them with Wolff-Parkinson-White syndrome that have an atrial fibrillation. Then, of course, the side effects are bradycardia, constipation with verapamil, and hypotension. Then other drugs like adenosine, this one is a very good drug for SVTs. It terminates the SVTs very quickly, but it has a very short half-life, about 10 seconds, and it's out of the system. So it's metabolized by the red blood cells. So the adenosine actually will activate potassium efflux, and it will also cause a transient blockage of the AV node. So this is very good for someone with an SVT. Digoxin, on the other hand, increases the vagal tone. It reduces the AV conduction, so it can be used for rate control in atrial fibrillation with heart failure. So adenosine avoided in asthmatic patients, in patients with AV blockade. Digoxin avoided in renal patients because it can cause derangements in potassium. So it can cause disturbances in the visual and as well as GI upset. And then adenosine causes bronchospasms and flushing, which is why we don't give it in asthmatic patients. So remember, class 1 are less commonly used today because they have a great risk of causing other arrhythmias. Class 2 and 4 are the mainstay for rate control in atrial fibrillation. Class 3, amiodarone, is quite powerful, but it affects many organs, so it requires serious monitoring. Class 5, adenosine is a drug of choice for the SVT, like I told you. So always consider any structural defect before prescribing any drug that is from class 1C, that is the sodium channel blockers. So coming now to question 8. So you have a patient admitted with pneumonia. A murmur is heard on examination. What findings points towards mitral regurgitation? Murmur loud on inspiration, murmur louder with patient in left lateral position, murmur louder over the second intercostal space, mid-clavicular line, a Corrigan sign, narrow pulse pressure. So already off the bat, if they're asking you a murmur is heard on examination, what points towards mitral regurgitation? Obviously, they're relating to the murmur, so it would be dumb to actually go for either option D or option E. But let me just show you a whiteboard and explain to you the way someone once explained this to me. So you have the first heart sound, which is what I'm going to be denoting here as S1. Then there's some silence in between. There's the second heart sound, which is split into two components. What is known as the A2 or the aortic component and the P2 or the pulmonary component. This is going to be predominantly making up the second heart sound or S2. Then there's some silence again. Then there's the first heart sound. Even the first heart sound is split into two because remember that the valves on the left side close a bit faster than the ones on the right side, but the human ear cannot distinguish this difference with the first heart sound, but we can actually distinguish this difference with the second heart sound. To actually get rid of this physiological splitting, you can actually ask the patient to take a deep breath in, hold their breath, then this will now be heard as a single sound. So this phase here is what we refer to as systole, and this phase is what we refer to as diastole. Okay, so this is what we are going to be referring to as diastole. Now, remember that there are valves that are there, the mitral valve. You also have another valve, which is the tricuspid valve. These are what we call atrioventricular valves. Then I'll group them together. Then you have the semilunar valves, which are the aortic valve and the pulmonary valve. So remember, during systole, blood is being ejected from the heart. It's being pushed out from the left ventricle. So to prevent this backflow of blood into the atrium, these valves that are going to be present in the mitral area and the tricuspid area are supposed to be closed. So there's going to be closure of these valves. Then in terms of the aortic and the pulmonary valves, these ones are going to open because that's when blood is going to be flowing out of the left ventricle. The opposite is true for when the diastole is happening because the heart has to fill up. So blood has to move into the atrium, eventually into the ventricles. So this blood is supposed to flow through the mitral and the tricuspid valve. So in these phases of diastole, the mitral valves and the tricuspid valves open, whilst to prevent backflow of blood from the large vessels back into the ventricles, the semilunar valves are going to be closed. Okay, so I hope that's like a normal basic physiology that is there. Now, if there's a problem with closure of the valve, we refer to that problem as a regurgitation problem, regurg. So regurgitation has to happen with the closure, meaning the leaflets are incompetent and the valves are allowing blood to get through. So if there's a problem with the closure, this is a regurgitation valve. So it means that mitral regurgitation and tricuspid regurgitation are predominantly going to give you systolic murmurs. On the other hand, aortic regurgitation and pulmonary regurgitation are predominantly going to give you diastolic murmurs. So these ones are diastolic murmurs. Aortic regurgitation, pulmonary regurgitation are diastolic murmurs. Mitral regurgitation, tricuspid regurgitation are systolic murmurs. Now opening, if the valve is stiff, it won't open so well. So this means that the valve is going to be stenotic. So stenotic valves, usually it's a problem that has to do with opening of the valves. So opening is a problem. So it means that aortic stenosis will give you a systolic murmur, and pulmonary stenosis will also give you a systolic murmur, whilst mitral stenosis will give you a diastolic murmur, and tricuspid stenosis will give you a diastolic murmur. But the predominant murmurs I want you to know about are murmurs for aortic regurgitation, murmurs for aortic stenosis, and then murmurs for mitral stenosis and murmurs for mitral regurgitation. Those are the ones that are common and are high yield for the purpose of your exam. If you actually work out murmurs like this, it's very easy to actually understand what is going on or what you're hearing in terms of the murmur. And remember that each of these heart sounds is auscultated at particular points of the heart. I'll show you diagrams of this, but it's auscultated at particular points of the heart. Okay, I hope that is clear enough. Okay, so now getting back to this particular question, we have, of course, a patient admitted with pneumonia, and they have a murmur that is heard on examination and what points against mitral regurgitation. Remember that the regurgitation is a problem with closure. So if it's a problem with closure, you expect this mitral regurgitation valve to be present in, to be present in the stage of systole. So this is going to be a systolic murmur. And usually murmurs that are of the mitral origin tend to radiate to the axilla, and they tend to be loudest when the patient is in their left lateral position. We call these changes in positions which are affecting the sound of a murmur, we call them as accentuation maneuvers. So off the bat, you can already tell that our answer there is option B. Okay, like I already mentioned. So what I was just from explaining is of course this particular diagram. You have our S1, you have our phase of systole, we have our S2, you have our phase of diastole. In the phase of diastole, you can also hear other additional signs like S3 and S4. I won't go into details of them in this particular video. We'll do that at another point. And of course, the auscultation points, the second intercostal space right of the sternum, that's where you hear the aortic murmur from. So, or the aortic valve is best heard in this area. If there's an aortic stenosis, because remember blood is shooting upwards like that into the aorta, it will tend to radiate towards the neck. So aortic stenosis will give you a murmur that radiates towards the neck. It radiates towards the carotids because it's like blood is splashing out in a force upwards. Then in terms of regurgitation, remember regurgitation, the aorta will rise and then it will curve downwards. So if there's a regurgitation, it's like the blood is flowing backwards. So sometimes you may hear it at Erb's point, which is this particular point at the left third intercostal space, the left of the sternum. We call that as Erb's point. You may be able to hear your aortic regurgitation from here. The pulmonary valve is best heard at the left intercostal space, second intercostal space. And again, if you have a pulmonary stenosis, it's going to be loudest in this area. The pulmonary regurgitation will also be loudest in this area. Tricuspid is heard at the apex, near the apex beat, so the fifth intercostal space, mid-clavicular line. Again, if you have the mitral valve rather, not the tricuspid. Tricuspid is the fourth intercostal space. The mitral valve is the apex beat. So if you have a mitral valve pathology, this is going to be heard, of course, at the mitral area, and it's going to be radiating to the axilla. So often this is what you must keep in to be able to take all this in, to be able to understand these murmurs to a greater depth. So I'll leave this on your screen. You can get a screenshot of this particular thing. The lecture is available for download on the course. So remember, a murmur is going to be loudest on inspiration. These are pointing towards valves that are affecting the right side. Then if it's the right intercostal space, mid-clavicular line, that's the anatomical landmark for the aortic valve. The mitral valve is heard over the apex, which is fifth intercostal space, left, mid-clavicular line. So the murmur that is loud in left lateral position is due to mitral lesions. And one that even radiates to the axilla, think of mitral lesions. Corrigan sign is these visible pulsations of the carotids that we tend to see with aortic regurgitation, but you may have other signs like Demusets, which is bobbing of the head, trebles, Quincke sign, which is pulsation of the nail beds, de Rozier's short, or de Rozier's sign rather, and many other signs that we'll talk about in another video. You also have narrowing pulse pressure in terms of aortic stenosis, but off the bat, we can tell this person has a mitral valve problem. Question 9, a 55-year-old patient presents to you with a history of having recently had a myocardial infarction with a 5-day hospital stay while on a business trip. He reports being told he had mild congestive heart failure then, but is asymptomatic now with normal physical examination. You recommend which of the following medications? A, an ACE inhibitor, B, digoxin, C, diltiazem, D, furosemide or Lasix, E, hydralazine plus nitrates. So this question here, very simple. It's pretty much testing you if you know which drugs actually have some mortality benefits in patients that are cardiac patients, especially those that have had a recent myocardial infarction. So there are different classes of drugs and those that are in heart failure. There are different classes of drugs that have proven mortality even from the different trials. Of these drugs, ACE inhibitors are one which are the gold standard because they've been studied for over years. But these are now being replaced by the angiotensin receptor blockers and the neprilysin inhibitors. So a drug like Entresto, the sacubitril and valsartan combination. So remember, your ACE inhibitor has been shown to actually prolong the patient's life, reduce mortality rate shortly after an MI, because they're going to be blocking your angiotensin converting enzyme, which will convert angiotensin 1 into angiotensin 2. So this will block the renin-angiotensin system, so it will reduce the preload, it will reduce the afterload. So there are other drugs which have been shown to have some mortality benefits, beta blockers, though now there's some conflicting data in the newer studies that are being released. Angiotensin 2 receptor blockers could be used as an alternative, because remember that the ACE inhibitors have a side effect of a dry cough. And then your aldosterone antagonists like spironolactone, there are some studies that have been done, like example the RAILS study and the EPHASIS studies, which have been looking at mineralocorticoid, mineral antagonist. Then generally, you also want to advise the patient for salt restriction and also moderate exercise. Digoxin itself is reserved for those with clear-cut systolic dysfunction, where it's going to help with the contractility of the heart, but this patient had mild heart failure. Calcium channel blockers, do not give them in acute heart failure. The beta blockers also in acute heart failure, do not give them. Nitrates and hydralazine can be used as an alternative, especially for those patients that cannot take ACE inhibitors for some reason. So here's a table showing you the drugs and how we often introduce these drugs, especially for patients with heart failure with reduced ejection fractions. The 5 classes that have shown benefit are the ACE inhibitors, the ANIs, which are the angiotensin receptor and neprilysin inhibitors, the beta blockers, the mineralocorticoid antagonists, and of course the SGLT2 inhibitors. Yes, the drugs that we use in diabetic patients, they have been shown there have been several trials that have shown some benefit. For example, the Emperor's trial that has been showing some benefits, especially even in patients without heart failure, without diabetes, or even in patients with diabetes, and those with reduced ejection fraction, we can actually use some of these drugs. So in terms of ACE inhibitors, enalapril is common in our location, lisinopril, ramipril, ANIs, sacubitril, and valsartan. These ones here tend to cause hypotension, so use them with caution. The bisoprolol, carvedilol, metoprolol, succinate. Remember, metoprolol exists in 2 forms. You have metoprolol succinate, which is the extended release, a longer acting drug. Then you have metoprolol tartrate, which is a shorter acting drug. So the one that has shown mortality benefit is metoprolol succinate, which is a longer acting drug. You have the mineralocorticoid antagonists like spironolactone and eplerenone, and as well as the SGLT2 inhibitors like dapagliflozin and empagliflozin. The mechanisms of action, I'm really not going to go through that because I think it'll be beating a horse that's already dead, and it's self-explanatory. But what I want to emphasize pretty much on this table are the key main points. Remember, ACE inhibitors, do not give them in a patient with bilateral renal stenosis. Don't give them a patient with a history of angioedema, or in pregnancy they're contraindicated. They tend to cause hyperkalemia and renal dysfunction, so don't give them in those patients with acute kidney injury. Often these are the first drug that we are often going to start. We start off at a low dose and we titrate every 1 to 2 weeks as we check the BPs, we check the renal function, we check the potassium levels. If you're using an ANI instead, you actually want to have a washout period of about 36 hours before you start your ANI, because remember that they may actually cause side effects of hyperkalemia. They may cause hypotension. So generally, for those that have a systolic BP less than 100, use these with caution because they'll lower the BP. So often when you're switching from an ACE inhibitor, you need to have a washout, and you start at a low dose and you titrate every 2 to 4 weeks. These ones are indicated for those with class 2 to class 3 New York heart failure, and they have replaced the ARBs and the ANIs. In terms of beta blockers, avoid them in acute heart failure, avoid them in asthma, avoid them with those that have bradycardia. But for those that are stable, class 2 to class 4, you can actually give them even post-MI, very good. Mineralocorticoid antagonists, the biggest thing is they shouldn't have any significant renal dysfunction because there's risk of hyperkalemia. With spironolactone, there's an additional risk of gynecomastia, while with the SGLT2 inhibitors, because they lead to glycosuria and a lot of excretion of glucose in the urine, they're pretty much going to lead to genital infections and recurrent UTIs. So here's a practical way in which you can actually introduce this drug. So the first ones that you usually add are the ACE inhibitors or the ARBs, or if you don't have them, or you have the ANIs, you can add the ANIs and then you titrate them until you reach your optimum dose. Then afterwards, once your patient has now stabilized, you add your beta blocker and you titrate that slowly. Once they're on an ARNI or an ACE inhibitor or an ARB and a beta blocker, then you can contemplate adding a mineralocortical antagonist if the renal function is okay and if the potassium allows. Then you can continue to add on the SGLT2 inhibitors, which are easy to initiate and there's no titration that is needed. And remember, if the patients actually come in acutely decompensated, often these medications are stopped because they may actually worsen the hypotension. Often, if they come in and they're edematous, we often stop the medication, put them on an inotropic infusion to actually keep their BPs afloat, diurese them, wean off the infusion, restart the drugs, address the trigger that led them to the decompensation. So we're going to be monitoring the renal function, the potassium levels, the blood pressure, as well as the heart rate. So question 10, a 72-year-old male presents to the ER with the chief complaint of shortness of breath that awakens him at night and also night cough. Further questioning confirms recent dyspnea on exertion. As you pursue the diagnosis of congestive heart failure using the Framingham's classification or criteria, you note the physical examination findings below. Which of the following findings is considered as a less specific minor? A, neck distension. B, rales. C, S3 gallop. D, positive hepatojugular reflux. E, extremity edema. So how I like to think about this is that which of these can be explained by many other conditions. That's how I like to think of this question. So you can pause the video, scream at your screen, write down your answer. So extremity edema, it can be explained by many things. This is the Framingham's classification. I already talked about a much more extensive one. So I won't really go through this over again. So to continue the rest of these questions, please make sure you do join our internal medicine course where you can actually find question 11 to 20 and you can find other things like free revision materials. We will also upload step-by-step internal medicine topic reviews that you have never seen on this channel before, and we'll have also other MCQ bootcamps after cardiology bootcamp is done. Do also join our YouTube membership if you so wish for early video access. Please do not pay for both because the videos that will be showing up on our membership may be similar to the video that is showing up on our online course. So pick one of the two. And of course, you may get some other additional videos on the YouTube membership as perks and be able to interact with me on a one-to-one basis and of course, quicker responses. I really hope you enjoyed this cardiology bootcamp. I know I forgot to tell you to grab your piece of paper and I'm sure you already grabbed your piece of paper. Until next time, my name is Dr. Moses Kazevu, to Zambia and beyond. Bye-bye.